Welcome everybody, welcome to another APSAD Insight webinar. My name is Jim Hunt, I'm one of the nurse educators here, and it's going to give me great pleasure in a minute to introduce Associate Professor Suzanne Nielsen. Suzanne is the Deputy Director of Monash Addiction and Research Centre in Melbourne. And she spent a lot of time trying to reduce issues around opioid harms. And one of the things that she's going to be talking about today is looking at new screening tools in relation to opioid use and chronic pain. Before we begin, I'd like to acknowledge the traditional owners and custodians of the land on which we're meeting today. I'd like to pay my respects to elders past, present and emerging, and I'd like to extend that welcome and respect to any Aboriginal or Torres Strait Islanders that might be joining us out there in webinar land. So thank you and welcome. I think you're going to enjoy today. I think Suzanne, she won't like me saying this, but she's probably one of the leading people in this field. So without much further ado, I'm going to hand over to Associate Professor Suzanne Nielsen. Thank you, Suzanne.
Great, thanks for the introduction, and thanks for having me on here today to talk about some recent work that we've just finished. So what I'm going to talk about today is some new tools that we've developed to help be able to look at clinical outcomes with opioids and hopefully contribute to better monitoring and greater safety around opioids in general. So just to give a little bit of background as to why we did this work, we know, I think most people are aware that there have been rising harms with all opioids in Australia, and particularly with pharmaceutical opioids over the past decade or so. And a statistic which I always find, good to remind us of how things have changed is that the average drug-related death in Australia today is a middle-aged male taking pharmaceutical opioids, and usually in the context of polypharmacy, and that's very different to the patterns of opioid-related harm we saw in the sort of late 1990s when we had very dramatic increases in heroin-related deaths. Amanda Roxburgh's done some very nice work recently digging into getting a bit more detail around those deaths, and in particular when she was looking at the pharmaceutical opioid deaths. Some of the findings were that, among those deaths with prescription opioids, we see that pain and mental health were more common issues among those deaths compared with heroin deaths. And actually from her published figures, when we looked at just those deaths with opioids for pain, we can actually see that there's quite a large number of those deaths that represent both people with chronic pain and a minority of those deaths that involve people who inject drugs. And I think often the assumption is with these deaths that the majority of these deaths are represented by people who inject drugs. And while that is a really key population where interventions are essential and prevention work is essential, I think often it's forgotten that actually there are a number of deaths that involve people who are prescribed these opioids, who are using them for chronic pain, and that we also need strategies that are appropriate for that population. Just to give a bit of a summary from some of the work that we've learned around opioid-related risks and help seeking. And most of this comes from the POINT cohort, which is has been led by Professor Louisa Degenhardt. And it's a cohort of a community-based sample of people who prescribed opioids for chronic pain. And this wasn't a population, it was more than 1,500 people on long-term opioids. And it wasn't a population who was recruited on the basis of experiencing any kind of problems. But we did actually find among that group, 1 in 4 actually met criteria for addiction as is defined by the American Pain Society. So they were experiencing symptoms like impaired control over use, compulsive use, continued use despite harm or cravings. And we also know that most of those population, 4 out of 5, in fact, have meaningful opioid overdose risks as per the CDC criteria, yet very few of them have knowledge around what the signs and symptoms of opioid toxicity are or how to respond. So there is a bit of a gap in kind of trying to reduce these opioid-related harms. We also know that from interviews with these people that around half or even higher, depending on what time point we're looking at, of the population have concerns about their own opioid use, yet very few are raising that with health healthcare professionals and seeking help. So we see a bit of a gap between people experiencing problems and actually receiving the care that they need. And from the work that we've done with healthcare professionals, we've also found that often they lack confidence in how to raise these issues and how to identify when problems might be occurring for patients. And this is a shame because we do actually have really effective treatment for opioid dependence, and we also have naloxone that's now much more widely available. So when we have these evidence-based interventions, but they're not getting to the people that need them, I think that's where we need to do more work. Also in this context of why we might need to improve monitoring of outcomes for opioids is the fact that we've had a lot of changes around access and availability to opioids. Some of those implemented quite recently. So new restrictions around prescribing with immediate and modified release products, new PBS listings with different restrictions on indications. And importantly, there's been a new requirement that when people are maintained on long-term opioids, that once every 12 months, they're going to have a review about whether or not those opioids should be continued. And so I think this requirement to be ongoing, having these ongoing reviews of how treatment is progressing does put more of a sharp focus on the need to have good processes in place to monitor outcomes and to be able to have that benefit of risk-benefit assessment for the patients. I did, before I dived into this seminar, also wanted to just do a bit of a shout out for another, I guess, very complimentary seminar that was on a few weeks ago, and the recording, I believe, is live now online. And this was a seminar that Nicola and Alice really looked at some of those long-term side effects and, again, talking about the risks and benefits with opioids. And I think if you're working with patients and trying to, I guess, have these conversations and help patients weigh up if they may want to continue on opioids or not. Both the tools that I'm going to talk about today and the information that was presented in this webinar, I think, provide really good background. So just in terms of, I guess, summarising the gap and what the research I'm going to present is aiming to address, is that we know that both for good clinical practice and also the changed PBS requirements, there is a need for improved outcome monitoring with opioids. And we know that people with on opioids for chronic pain often have multiple risk factors. They might not raise concerns unless they're asked, and they might not be getting clinical benefits, or the risks might outweigh the harm for some patients, but not all patients. And I do like to continually stress that there are patients who have very good outcomes with opioids. They may be on a relatively lower risk dose and they're getting good benefits. They're able to achieve things and have good functionality because of the opioids that they're prescribed. And it's not about having opioids, no opioids for anyone, but it's about being able to identify which patients are having really good outcomes and which patients that risk might outweigh any benefits that they're experiencing, and being able to help balance that in a conversation with the patient. So the work that I'm going to present today is about some tools that we've developed, and what informed the development of these tools was really looking at what is best practice in terms of monitoring for outcomes with pain. And there's a framework which was originally called the 4 A's, which has kind of morphed into the 5 A's of pain treatment. And you'll see that I've added another A, so now there's 6 A's. But the original domains that Pasek and Weinreb had identified as being key things to monitor when people are on long-term opioids are the following. So analgesia. So are people getting meaningful pain relief from the opioid medicines? Activity, so how are people functioning? What are they able to do with the opioids that they wouldn't be able to do otherwise? And how is the opioid analgesics contributing to quality of life? Adverse effects, so side effects, obviously, again, very important when we're talking about quality of life. And also addiction-related or aberrant behaviours. And I know that term aberrant behaviours isn't one that's very popular, but I guess that's that domain of where people might be experiencing problems, starting to develop sort of addiction-related side effects with opioids. The 5th A is affect or mood, and we know that depression is often commonly comorbid with chronic pain. And then I've also flagged alcohol, and I'll go into a little bit more detail about that as we go. But essentially, these are key areas which are important to monitor when people are on long-term opioids. And so the work that I've done is to develop this brief 12-item routine opioid outcome monitoring tool. And the idea is this is something that could be used. It's been, the wording and the content has been developed so it's relevant for all patients. And having something that you can use with all patients, I think also helps to reduce feelings of people being targeted and reduce stigma that any particular patient is being signalled out, that these are really important outcomes for any person who's on long-term opioids. I guess also just to flag that early approaches often were more centred on sort of risk screening before starting opioids, as opposed to necessarily monitoring people as they go. But we do know that this risk is dynamic. Things can change for people, and often we see with when problems are emerging with prescribed opioids, it can be in the context of psychosocial stresses or other things that are happening for patients. So it is important to monitor as time goes on. And we know that from these tools like the opioid risk tool, while they make sense, they actually aren't very effective in predicting who's going to develop problems later on. So again, this supports the idea of ongoing monitoring. So just to give you a bit of an overview of the room, you can see the tool in a sort of PDF form on the right-hand side. I will give you links, and you're absolutely free to download and use this tool if you are interested in it. There's a downloadable version later on, but just to kind of show how the questions in this tool sort of link up to these domains. So in terms of analgesia and activity, we've got the PEG tool, and I'll go into that in the next slide in more detail. But that assesses both current pain, but also enjoyment of life and general activity in the context of the pain that people are experiencing. In terms of measuring adverse events, we've got questions on constipation and also on sedation. And then I guess you can also conceptualize addiction while being a domain on its own as also being a side effect that we know can happen with opioids. In terms of measuring addiction or aberrant behaviours, we developed a 4-item validated tool that is reliable for screening for people who might meet criteria for opioid dependence or opioid use disorder. And I'll go into that in more detail. And then we've got the PHQ-2, which is a very commonly used primary care screening tool for anxiety or depression. And then a single question for screening for risky alcohol use, and that's with alcohol as a 6A. So now I'm going to walk through each of those tools and hopefully give you a little bit more information. So this is the PEG, 3 items that assess in the past week how bad somebody's pain was on average over the past week, but also importantly, how pain is interfering with both enjoyment of life and general activity. And I think that actually the second 2 questions are probably the more important questions when we're talking about how somebody's able to function and whether or not they're getting benefit from whatever analgesic approaches that they're taking, is if what they're doing is allowing them to get enjoyment out of life and you know, get on and do general activities that are important to them, be it, you know, visiting with grandchildren or being able to go to work or, you know, whatever it is that's important for that person. So in terms of what the PEG score mean, in general, 0 is obviously, you know, no pain in the past week. But when we look at what the other scores mean, generally sort of 4 or less is considered to be sort of a range of mild pain, and sort of, you know, 5 to 6 is more moderate to pain. And when people are sort of rating their own pain or the effect of that pain on their life as a 7 or more, that's considered to be severe pain. And I guess when you're interpreting these scores, and if people are on strong opioids and they're still experiencing, you know, severe pain despite being on those opioids, it might suggest that, you know, perhaps that their pain management isn't optimized and there is room to do more. Probably the other factor, which I think is just as important to consider, is how these scores are changing over time. And particularly in the context of changing medications or maybe a trial of opioids, etc. If you're able to measure these pain scores at baseline and then see whether or not a change in medication results in any kind of improvement, it can help to provide some objective information about whether or not that increase in dose has allowed somebody to actually have an objective reduction in what they're self-reporting as their pain over time. And that can be really valuable in assessing whether or not new interventions are helpful. I can see someone's asked if it's possible to get a copy of the slides, and yes, absolutely, it's possible. And I also see someone ask, how do you rate someone who describes their pain as 11 out of 10? And I think if someone's saying their pain is 11 out of 10, again, that's really reflecting that they feel like their pain is totally, off the chart, that their pain is really severe and not well managed. And so I guess those scores reflect the kind of distress that somebody is in if they feel their pain is, if they're calling it 11 out of 10. So the next A's in the kind of 5 or 6 A's that we talk about are adverse effects and also addiction-related or aberrant behaviours. Now, I consider all of these to be somewhat in the domain of side effects from opioids, but in particular, some of the more severe side effects are sedation. And this is important for a number of reasons. We know that opioids are linked to falls risk. And so if people are sedated, and particularly sedated during the day, that might reduce their quality of life. It might add to overdose risk. It might affect driving safety, and it certainly affects quality of life if people are so sedated by their medicines that it is hard to get off the couch and get out and do things. In terms of overuse or addiction-related behaviours, again, talking about these signs of loss of control, overuse, compulsive use, craving, and continued use despite harms, and I'll go into that a little bit more in a few slides' time. And then constipation is the other key side effect. So I'm going to talk about constipation now just very briefly. We know constipation is really common with opioids. It might be a bit less common with some of the new formulations which are intended to address that side effect, like the oxycodone naloxone. But constipation can really impact on quality of life. And not only that, there are some important lifestyle factors that can reduce this side effect if it's discussed. But what we do know is that not all patients are using appropriate laxatives, and I've just got some examples there of where some laxatives might be particularly indicated with non-responsive constipation, like osmotic laxatives, but there are other laxatives like bulking agents that might actually make things worse and increase the risk of bowel obstruction, particularly if we've got someone who is not mobile. So again, asking about constipation, asking what people are taking for constipation is a key thing to do, but often patients may not raise it themselves. It is an embarrassing thing to bring up. And I have just flagged a resource there in terms of if you are interested in reading a little bit more about constipation as a side effect and its management, there's a link there that you'll be able to access. In terms of addiction or opioid dependence, I think many people are probably familiar with this concept, but just to confirm in terms of how it's defined, to meet the criteria of opioid dependence, per sort of ICD-10 criteria, it's meeting 3 or more of these criteria during the past year. So having a strong desire or a sense of compulsion to take the substance, difficulties controlling use. There is a withdrawal state and evidence of tolerance, although I would note that when we're talking about opioids, when they're being used solely for medical treatment, these 2 symptoms don't actually contribute to the diagnosis of opioid dependence. So it would really be these other 5 behavioural symptoms that would be considered. So again, persistent use despite harm, a real focus on taking the substance and perhaps less interest in other things in someone's life, and neglect of alternate pleasures. So that's the formal definition of opioid dependence. As part of the Room tool, we have 4 questions in there that we developed as part of the program of research that I'm talking about today, and that was to develop a brief screening tool that would be able to be used with people who are prescribed opioids to identify who might be most at risk of developing opioid use disorder or opioid dependence. These questions, we actually developed them in consultation with people with lived experience and using the POINT database, a cohort study we identified questions that were acceptable in their wording to be able to ask people who are prescribed opioids for chronic pain, and that when asked in combination were pretty effective at differentiating between people who were and were not experiencing problems like opioid use disorder. But they had language that was acceptable, and there are lots of screening tools for opioid dependence, but most of the questions actually have wording that really isn't appropriate for or relevant for people who are taking opioids for chronic pain. So, for example, there's questionnaires for opioid dependence, a rapid opioid dependence screen that has questions like, do you feel dope sick in the morning? That kind of language just isn't relevant for people who are taking opioids for chronic pain. So we're able to develop this 4-item screening tool that is effective and has language that we've determined is acceptable for this patient group as well. So that's the OWLS. The 4 domains in the OWLS are sort of overuse or using opioids for other purposes, being worried about your own opioid use, losing interest in usual activities, and feeling slowed down, sluggish, or sedated. And again, there's the references for those tools, and you can download them as well. So to score the OWLS, essentially, if people endorse 3 out of 4 of those criteria, they are very likely to meet criteria for opioid use disorder. And we validated this using a diagnostic interview. And so in terms of interpreting these scores, if you are using the room tool, if a person has endorsed 3 out of the 4 symptoms, I would be looking at doing a more detailed assessment of whether or not they are experiencing opioid use disorder or opioid dependence, and what might be an appropriate treatment for them. I would also say, though, that if people are endorsing any one of those items, it's worth a conversation. But in terms of endorsing 3 of those items, it really is prompting a more detailed assessment, but also having a look at other risk factors. So we know that people who have meet criteria for opioid use disorder are at an increased risk of opioid toxicity, or what's often called an overdose. They may need additional benefits and supports around their opioids. That might just be in terms of more structured supply, so a staged supply where they're not getting a month's supply at a time, but maybe you're getting a week's supply at a time, so it's easier to manage those opioids. And for those people with more severe opioid use disorder, if that's identified through using the room tool, to be looking at whether or not a referral for opioid agonist treatment, so for example, buprenorphine and methadone are evidence-based treatments which are effective for people with chronic pain and opioid use disorder. So that might be a pathway that you go down where this is identified through screening. But I would flag that it is really important to acknowledge that there are important barriers for treatment, and that this isn't a quick conversation. This is something that you might start to set up with a patient over a period of a couple of conversations at least, to be understanding their risks and benefits and what they're experiencing, and whether or not those kinds of treatments like methadone or buprenorphine might be appropriate for the patient that's in front of you. And again, if you're in primary care or perhaps not an alcohol and drug treatment setting, to be working in collaboration with those settings if you feel like you'd like that extra support for patients who are prescribed opioids for chronic pain to move towards medication-assisted treatment for opioid dependence. So just in terms of those 4 items, in terms of if a patient endorses any of those and you're using this for screening, I would recommend that would be a really good prompt for starting a conversation. So looking at if someone is endorsing using opioids for other reasons, so if someone says they're using their opioids for sleep or stress, I think it would be really good to start a conversation around understanding if that person might be interested in exploring other strategies, evidence-based strategies for insomnia, or to help if they're feeling stressed and help cope in those times of stress. It isn't ideal that someone's using their pain medication to cope with stress, but it certainly is understandable, and particularly in the absence of other coping strategies. If a patient's endorsing that they're worried about their use of opioids, it's really good to ask what aspect of the opioid use is it that's worrying them, and to try and understand a little bit more about that. And we know that this worry can come for a range of reasons. For some people, it might be because they are experiencing a loss of control, or they're experiencing harms. But we also see people that are worried about their opioid use because they're worried they're going to be able to continue to access it. We certainly hear about patients, even patients with in palliative care situations, who are scared to take their opioids because they're so worried about dependence. So if someone is endorsing this item, I think it's really important to have a conversation around what is it that's worrying them, as opposed to just using it as a tick box kind of scoring system. In terms of if people are reporting losing interest in usual activities, it is good to again explore, whether opioids might be becoming a focus in their life, to the expense of other things in their life. But also sometimes losing interest in activities could be related to other mental health symptoms. And we do know again that there is high comorbidity with pain and depression. And then that final domain that the screening tool covers is feeling slowed down, sluggish or sedated. And again, I've already mentioned that can really impact on people's safety with falls, with driving, with their quality of life, and also to, I guess, have a mind to whether or not there might be interactions going on with other medicines that they're on. So if people are on benzodiazepines, atypical antipsychotics, which are probably a little bit too commonly used for sleep in this population, pregabalin, again, we've had concerns around interactions and overdoses with pregabalin. Again, there might be a role for kind of trying to understand more broadly what medications people are taking that could be contributing to those symptoms. But I have just highlighted on the bottom of the score, when we have this screening tool that might help identify opioid dependence among people prescribed opioids, that I absolutely would reinforce that this isn't something that's used to work out if somebody should be cut off their opioids. And I certainly wouldn't be making any changes to a person's treatment plan just based on what they score on this screening tool. This is really a prompt for a more detailed investigation, or alternatively, it can be an easy way to ensure that those problems aren't occurring and that you've sort of checked that off. But it's not something that should be changing a treatment plan without a conversation about all of these kinds of factors. So moving on to the fifth A that's covered in the room tool is affect. We know that among people with chronic pain, around half meet criteria to moderate to severe depression, and we see that 1 in 5 have attempted suicide. So it is really important that we are monitoring these kinds of things for people who have chronic pain and are prescribed opioids. So we've included in this screening tool the PHQ-2. It's a very short tool, but it's really well validated to identify people who might be experiencing depression or anxiety. And if people are scoring 3 or more, and you can see the scoring here for these 2 questions, if they have little interest in doing things or feeling down, depressed or hopeless. If they're reporting these symptoms on several days, it's a score of 1. On more than half the days, a score of 2, and nearly every day is 3. So a total score for those 2 items of 3 or more, again, is a prompt that you need perhaps do a little bit more investigation and use a longer kind of assessment to look at how that might be impacting on people. And then the final A is alcohol use. And this is, I guess, something that I've added in as the 6th A. I've kind of referred to it as the new A on the block. But we do know that 1 in 3 people who are using opioids for chronic pain report a lifetime alcohol use disorder. So it does make sense to be asking about alcohol use. We also know that alcohol use is really commonly implicated in opioid-related deaths. And more importantly, when we're talking about quality of life, alcohol can affect sleep. It can really kind of affect sort of, people waking up during the night and having poor sleep, and it can interact with medicine. So there's a whole range of reasons why it makes sense to be asking about alcohol use. And I think that there is a real move in primary care in general to be asking about alcohol in the same way that we ask about smoking and smoking cessation. So this is just a single question that's been validated to be very reliable for identifying people who are drinking in risky ways. So just asking in the past year about how many occasions that they've had 4 or more drinks for women or 5 or more for men. And again, in terms of what to do with that response, if people are responding positively to that risky drinking screening, that would indicate the need for a more detailed assessment. And from that more detailed assessment, so some of these longer tools like the Audit C or the audit to determine what the treatment plan might be. So again, thinking about those factors like interactions with alcohol and effect on mood and sleep, but also thinking about a brief intervention around risky alcohol use. I don't have time today to go into a lot of detail around what a brief intervention looks like, but there are a range of kind of suggestions. I would recommend this article that you should be able to link to from the slides in the chat box to be able to look at how a brief intervention might look, and using some of these frameworks like feedback, listening, advice, goals and strategies, and using tools like motivational interviewing to talk about how somebody might value changing that substance use. So that's an overview of what's contained in the room tool. I think some of the key questions that I think people might ask is whether or not these tools are validated. So I did, without going into the research in great detail, want to reassure people that we developed these tools, we looked at the wording and we tested it in populations of people who were prescribed opioids for chronic pain. We originally developed the OWLS tool for opioid use disorder, opioid dependence, in using data from people who prescribed opioids for chronic pain, and then we revalidated it in a separate population of people prescribed opioids for chronic pain. So we feel fairly confident that these tools do what we expect them to do when they're used in this community, in this population. And then the other tools that make up the room, the PEG, the PHQ-2, the alcohol screening question, they're all validated questions that have been widely used in primary care, but we did again revalidate these tools for self-complete format and online complete format in people who are prescribed opioids for chronic pain. And those two papers have just come out in press, and I'd be happy to share them with anyone that wants to read into more detail. The question I think is probably even more important than if it's validated is it acceptable to patients? And again, this is something that we explored through an implementation study and also through working with people with lived experience of chronic pain and prescription opioid use as we were developing the tools. So we did get that input on the wording as we were developing the tools, and we also completed a validation study where we asked people after completing the tool how satisfied they were in terms of the time it took to complete the tool and the ease of completion. And the median score was 10 out of 10, so we didn't identify any problems there. It's relatively quick to complete, takes less than 5 minutes. Also, we did an implementation study in a community pharmacy setting. And during that study, we had community pharmacists having patients complete this tool on an iPad in community pharmacies. And we had an evaluation survey that was attached to that study. And so from that study, which was really looking at it in a clinical setting, we had people, on average scoring sort of 8 or 9 for ease of completion of the tool in that setting, relevance of the information that they received. So this is probably more a comment on their interaction with the pharmacist as a result of completing the tool, getting both the relevance of the information they received and the usefulness of the resources. But so far, everything that we've done supports that these questions and this approach is acceptable to patients themselves. Just to give you a really quick kind of flag of what the results look like in the pharmacy study, we had 152 patients that we screened using the Room tool from 23 pharmacies across New South Wales and Victoria. What we actually found when we used this tool in practice is that the level of problems that people were experiencing was quite high. So the average pain scores was a 6 out of 10, and I think we had around 30% of the population were reporting that their pain or the effect of pain on their life was a 7 or more. So it's quite severe pain despite being on opioids. So really identifying an opportunity for improved pain management and not just the opioids that they were currently on. We had around 3 in 10 reporting side effects like constipation and 6 in 10 reporting sedation from their opioids. So again, clear evidence that that we see people are having negative impacts from their opioids on their quality of life. We had 4 out of 10 that screened positive for opioid use disorder. And we had a similar number reporting drinking at risky levels, and about 1 in 5 who met the cutoff for depression. So again, I think this really highlights that when we use these kinds of tools in general community samples, that there is quite a level of kind of ongoing problems with opioids that people are experiencing. Their treatment outcomes could be improved if we're able to address these problems. Interestingly, when we looked at risk per the CDC criteria, so things like being on high opioid doses, medicine combinations, and also these substance use disorder risk factors. 4 in 5 actually had at least one risk factor for overdose or opioid toxicity. And we found from the evaluation survey with a subset of these patients that as a result of doing the room, that most patients had a conversation with their pharmacist that was helpful, and actually a further 25%, in addition to speaking to their pharmacist, actually went back and had a referral appointment to discuss these issues. So we did find that using this tool in practice means that we were able to have those conversations that weren't necessarily happening otherwise to be able to start to address some of these problems. Probably slightly disappointingly, we found that only one person received naloxone as a result of doing this screening. So we probably have some room to improve in terms of increasing the prevention sort of strategies around opioid risk. So I guess just finishing up in terms of discussing opioid-related problems. Again, I think it's really important always to be discussing this from the patient's perspective and to be acknowledging or highlighting any benefits that they might be getting from their opioids and being able to balance that with any concerns that they might have or that you might have identified around opioid medicines. I think the other thing that's really important to bring into these conversations is that our knowledge around opioids has really changed. And people might be wondering why we're asking about opioids now. We know on average from our point cohort that people have been on these opioids for 5 or 10 years. But what's changed in that time is what we know about opioids. So we actually now know that that those benefits from opioids aren't actually sustained with long-term use in chronic pain, and actually people can become sort of their pain sensitivity can be increased through opioids, and they might not actually be getting long-term benefits. And it's worth checking in about that, seeing whether or not they're interested in trying reducing the dose to see if that helps. And we do also know that strong association with dose and risk and overdose. And so again, this highlighting kind of identifying those patients who might be on a higher risk kind of medication profile. We also know that we have strategies now. We have Naloxone, which is a really effective tool and a good prompt to discuss how we might prevent some of these mortality statistics that I had at the start of the presentation. And I just wanted to flag, while I am flagging resources around chronic pain, is that we have also worked with patients who are prescribed opioids for chronic pain and community pharmacists to come up with a set of resources that are really talking about naloxone and opioid safety in a way that's really salient for people who are prescribed opioids. And we know that there's absolutely fantastic resources out there that have been developed for people who are injecting opioids or using opioids in other contexts, but a lot of the language in those wasn't relevant for people who were using opioids for chronic pain. So again, these you can download these resources. There's leaflets and there's animations to help, I guess, have better conversations. And again, we co-design these materials with people who are prescribed opioids for chronic pain, and we got really good feedback from them that these were kind of worded in a way that was, acceptable and clear for people. So just to let you know, those resources are out there. And last slide there, obviously, it's really easy to develop a tool, but it's really around how we bring up these conversations that's really important. And okay, and this is literally a quote from one of the people that we worked with, and who had problems with opioids and chronic pain. And she had said that the right message delivered the wrong way can be really harmful. And so it is really important about how we bring these conversations up. We know that chronic pain and opioid dependence are both very stigmatized conditions already. Patients feel incredibly judged with all the focus that there has been on prescription opioids at a policy level. And so really thinking about how we can use tools like the room that we've got here with evidence-based communication strategies like motivational interviewing to be able to help patients be able to be involved in that decision about whether or not they do want to continue on opioids or make a change with their opioids, and how they might get better sort of outcomes with their pain. So I just wanted to kind of flag that. And again, probably not a lot of time to go into sort of motivational interviewing strategies, but I have put a link to some resources here at the NPS website, and also a short YouTube video around motivational interviewing with chronic pain. So just before I finish, I did want to, I've got a long list of acknowledgements. This was, I guess, a body of work that happened over a couple of years, and there were lots of people who were involved at different stages. So to acknowledge all of those people, the advisory board that helped in the development of these tools, the many pharmacists, participants, people with lived experience that gave us advice along the way or participated in various stages of the research. The screening tool for opioid use disorder was developed through data from the point cohort, and some of those investigators I've listed here, in addition to a whole range of investigators that helped on the later stages of the work, and Alison Ritter in particular, who was my sort of mentor through doing this work. And we received funding from a whole range of sources, including the NHMRC, a couple of the primary health networks, and also a Mind Garden seed funding grant, and the Naloxone material development was funded through the Victorian Department of Health and Human Services. And if you want to access any of the information that I've presented today, you can download it all from this one website that you can see at the bottom of the screen. And if you have a phone and you can kind of hover it over the QR code, that'll take you straight to the website as well. So that's it from me. I think we can open up for, sorry, the fly buzzing around me. I feel like Mike Pence. I think we can open it up for questions or comments or ideas.
Thank you, Suzanne. Thank you for a clear presentation of what looks like a really useful tool. So thank you for that. We know I work in the addiction field, or, you know, alcohol and other drug dependency. And many of our clients come in with pain as one of the reasons why they end up in our service. So having what looks like a really simple tool to add to our arsenal to be able to screen and support those clients looks like a useful thing. So thank you for that. We have had some questions come in. First one, Victoria has real-time reporting. And the question was, has this changed the impact around prescribing of opioids to this cohort of people, or even, you know, people accessing treatment, you know, regarding pain and opioid use?
Yeah, that's a really good question. So we have had the Safe Script program, prescription monitoring. It was introduced in, I think, April 2019 across the state in a non-mandatory way, and it's been sort of mandatory since April this year, although obviously in the time of COVID, the focus has kind of shifted away from that somewhat. So yeah, so I guess we don't actually have really any clear data from my understanding of what impact that's had on clinical outcomes. So we can see at a high level that the OME, or the average opioid dose that people are being prescribed, or the average opioid sort of supplies going out, has reduced, but we don't actually know if that's targeted towards those people who are high risk, or if that's more of a reduction across the board. So that's really important work to understand. We have done, we're just in the midst of doing a little bit of analysis looking at how patients who might meet kind of those orange and red flags on prescription monitoring might align with those patients who identified as being at risk with the room tool. And at a very high level, it seems so far that those two groups don't actually overlap. It's a Venn diagram. So some people have risks on the room tool, some people might be flagged in Safe Script, and some people might be both. But there are actually a number of people who wouldn't be picked up on any prescription monitoring who actually would be at significant risk through this clinical assessment. So I think that prescription monitoring, it kind of does flag some of those high-end people. It particularly flags those people who are on high doses, and we have seen a real focus on dose, but it doesn't necessarily pick up many of those other concerns. It won't differentiate between someone who is experiencing opioid dependence and opioid use disorder and someone that isn't. And it's not going to pick up some of those risk factors like, you know, alcohol use or, you know, other kind of substance use in combination with opioids. So I guess we would expect that some of those, you know, really clear high risk, seeing multiple doctor kind of presentations might be picked up through prescription monitoring. But we also know from our mortality statistics that that's only a very small part of the mortality statistics. And so I guess thinking about how prescription monitoring has an important role, and it would identify some people. But if you could pair it with a clinical assessment, you're probably likely to pick up a greater range of people who might be at harm. And I guess, particularly if you are going to be talking about, looking at prescription monitoring and having a conversation with a patient about what you're seeing there, if you compare that with also understanding their outcomes with their opioids and how that might inform, where you might refer them to, that might be helpful. There's been a bit of a blanket suggestion that if someone comes up with a red flag, you might refer them to a drug and alcohol service, and that might not be appropriate. And if you're able to do a clinical assessment like this, it might have a more targeted referral of which patients would benefit from drug and alcohol services versus where it might be a pain service or something else that's more relevant.
Makes sense. Thank you. With reference to your tool, it's now the 6 A's. Somebody's asked in that process, when do you screen for pharmacotherapy risk? So you mentioned the alcohol complications, but obviously there are complications with opioids and other pharmaceuticals that might be prescribed. Might not be an issue with real time, as you were talking about, but particularly if someone was accessing multiple prescribers, that sort of thing.
Yeah, so when we did the trial in pharmacies, the implementation trial, we had, in addition to the patient completing this on an iPad or a computer tablet, we also had a couple of pharmacy flags that they would tick. So if the person was on a high dose or a high risk combination or had multiple prescribers, that the pharmacist would tick this, and this was before prescription monitoring was made mandatory. And so both of those sets of information would go into basically a summary for the patient and the prescriber, and a prompt to offer naloxone if those risk factors were identified. Now that prescription monitoring is available in Victoria, obviously those flags come through that system. But if you were using the Room tool in isolation of prescription monitoring, those are other clinically important things that you might assess. And I guess what the Room tool gives you is what you can't get from that kind of prescription data. It gives you some of the clinical information, but I think it's an excellent point that bringing those two sources of information together is going to give you a more complete picture than just one of them on their own.
Agreed. Remaining with questions about the tool, do you see this tool as being used as a one-off assessment kind of thing, or is it something that you would use repeatedly through someone's course of treatment?
So I think it's more that you would use it repeatedly. So I think it's something that you're going to be able to identify if problems are emerging, if particularly when it comes to both opioid use disorder and some of those side effects. We know constipation is probably more likely to happen at the start of treatment. Some of those other opioid-related problems are more likely to emerge. Things like, depression or mood, that can change as people go over time. So I think it is important, and that is the kind of the 5 A's or 4 A's original framework. That was something that was flagged as something that you would do continually over time. So I would recommend that these are the kinds of, and whether or not you use the Room tool or just focus on those key 5 or 6 A domains, I think they are the key domains that are recommended to keep an eye on over time for people who are prescribed opioids, and particularly even just looking at that score for pain to be able to see whether or not the kinds of things that someone's doing for their pain, is that helping, or is their pain, getting worse? And so often those objective measures can be really helpful on both the positive and the negative. So if somebody was, saying their pain was an 8 out of 10, and they've maybe done a pain management course and they've had some changes in their medication, and now they say it's a 6 out of 10, that's actually quite helpful to be able to reflect back and say, oh, it actually, it does seem like the things that we're doing are working, and, to give you a bit of a clue to keep going in that direction.
I think, I agree. I think equally it can look, if you're looking at that holistic, how's it impacting in your life? Pain isn't always going to get worse just because of opioids. It will get worse because of other stresses and other factors that are compounding in your life. I think doing it repetitively would actually allow you to extrapolate some of that, so that it breaks that connection that opioids are the only solution for managing pain, and it allows that more holistic look. So I agree. I think that's a good call. Somebody obviously really liked the tool, and they've asked, is there any tools like the Room tool for monitoring around benzodiazepine prescribing that you're aware of?
There are not that I'm aware of, but maybe I could put that down as the next thing on my to-do list, because I think that is another area where we do have, I think you could draw a really similar kind of line in terms of the kinds of problems that can emerge and the fact that these medications can often go on for a long time without benefits, but it probably would look slightly different because the underlying indication is, potentially anxiety or insomnia. But I do think that those general domains, if you replace pain with monitoring for, how people are going and whatever the reason that they're taking those benzodiazepines for, that probably would be a sensible framework for looking at, comparable outcomes.
Sure. When you were doing evaluation of your tools, somebody's asked whether there was any possibility of having control groups. So, for example, we know that pain can certainly lower somebody's mood regardless of whether they're on opioids, for example. So was there any comparison with the control group when you were looking at your study?
Yeah, so I guess the aim of this study wasn't to look at whether or not those outcomes were occurring in people, because we already know that those are, well-established problems that can occur with opioid treatment, but more looking at how we could support assessment and better conversations in the pharmacy setting around those problems. So we didn't have a control group, but we had pre and post measures of pharmacists' confidence around having these conversations. And we actually found that the training and using the tool lifted them up from an average of a very low amount of confidence to raising topics like unmanaged pain and opioid use disorder and alcohol use to sort of a moderate confidence. I think the next step for this is really looking at, and I didn't go into a lot of detail around the research. I did do a recent seminar for ENDUC, and you can probably look that up and watch if you want to learn more about the research, or email me and I'll send you a link to that. But I think the next step was really around how we can support pharmacists to do this better. We validated the tool, but how can we support those conversations happening, and what actually happens as a long-term outcome from those conversations? So I think that's the next step of the research, and then we would have a control group to look at where we have an intervention and see if that does improve over a control group. So we would be looking at that. But the pilot study was really around how does it work, and importantly, was it acceptable to patients and pharmacists to be able to do this kind of screening?
And kind of on that, talking about the acceptability of the tool, for people that are on opioids for pain, obviously with the media and the press and everything that's reported, there are concerns about them having their prescribing stopped or reduced or whatever due to concerns. Do you think that influences scoring when they're reporting, how severe their pain is and that sort of thing? Looking at your results, it didn't seem that they were scared to score high, but I'm interested in your experience.
Yeah, look, that was a concern that was raised, and we did want to see whether or not people would endorse these symptoms. I mean, we had people filling out these on a iPad that they were giving to the pharmacist. So, but we do actually know when people self-report, answer a self-report question, as opposed to actually just having the pharmacist ask them directly. Even if they know that the pharmacist or the healthcare professional is going to see that information, people are more likely to respond and endorse symptoms when they're doing it sort of in a self-report way. So I think that was one of the reasons why we went with that format. And as you say, we saw quite high levels of endorsing all of these problems in a community pharmacy setting. Look, there may be people that don't, for whatever reason, feel that they're going to say yes to those questions in that setting. But one of the concerns, the main concern that we sort of have with opioids, is that people are concerned, but they don't necessarily get help. And so for that group, I think having that opportunity, having a structured way of answering these questions, being able to answer it in a self-complete way so that you're not having that, maybe in less comfortable interaction when you're gathering that information. It does seem to be an effective way to be able to identify those problems in a clinical setting. We also had in the implementation study, those responses were automatically scored and actually produced a leaflet for the patient and a leaflet for the patient's prescriber summarising the results. So the pharmacist was able to go through and say, based on your score, either it seems like there's something that we could discuss a bit further, or it doesn't seem like you're experiencing this at the moment. That's great. So we were able to have kind of normative responses and kind of a prompt for that conversation to, again, support those conversations happening, and also importantly loop back in with the prescriber, so it isn't just happening in the pharmacy, but the prescriber has that information as well. And I think all of those processes were helpful in getting that information out, but also being able to do something productive with it and be able to have that improved care.
Perfect. I don't have any more questions specifically regarding the tool, but I do have another couple of questions which, knowing your expertise, I'm sure you're going to be able to answer. Somebody mentioned, and I think you probably saw it when you were doing your presentation, somebody mentioned about bowel motility, and there was certainly a link in your presentation that you referenced, which might answer how you can address some of those issues. But somebody else has asked, why is constipation less common with the opioids that we use in QOTP, so the Suboxones that have Naloxone on board? Why is constipation less of an issue with them? Do you want to respond to that?
Well, I guess firstly I'd say that we do still see constipation as a problematic side effect for people who are in methadone and buprenorphine. So it's not that it isn't a problem. We often don't ask all of our patients about it, and so if we did, we might find that it is a problem for some patients. I think one of the things, and we know that with the oxycodone naloxone product, that and potentially with Suboxone as well, that when you have a small amount of naloxone that goes into the sort of the gastrointestinal tract, that can reduce constipation, and also that sometimes people do get that side effect can settle down over time. But I guess, I mean, I think it is important to be asking all patients who are on long-term opioids about whether or not that they are experiencing constipation as a side effect. And I know when I was sort of a pharmacist and dosing sort of methadone and buprenorphine every day and talking to patients, you know, often you have those opportunistic discussions about diet, whether or not people were able to access sort of fresh fruit and vegetables, whether or not they're able to drink plenty of fresh water to drink, get enough water, as opposed to often people are often getting a lot of their liquid through, maybe caffeinated products. And so often there is a little bit of opportunity to discuss that as well. But yeah, it is not everybody experiences it. We have 30% in our sample. We do have up to sort of 80 or 90% in some studies find that with acute pain or acute opioids. So it does vary between people.
Sure. Certainly for me, it was something I experienced. I had a motorcycle accident a year ago, and for me, the pain wasn't as bad as the constipation. So I would rather have the pain and not have the constipation. That was a choice that I had, but I appreciate that it's a variable thing. Another question that we have is something that we obviously experienced in 2018, and I know you saw this before you started your presentation, have responded a bit, but we have some time, so you may want to say something of your experience down in Victoria, and that's that New Zealand is looking at changing their scheduling of codeine apparently, and they're looking at changing it from an over-the-counter preparation to something, I assume, that's going to be available on prescription only, which is what we did. So perhaps, and the person saying, is there any advice, anything that you can tell us that we might need to brace ourselves for? So just what your experience was down in Victoria.
Yeah, it's interesting. Actually, I know that you had an excellent presentation on codeine dependence. Was it 2 weeks ago or last week?
Yeah, 2 weeks ago.
2 weeks ago. I watched the recording. So so I would, go have a look, check that out. That's quite a good talk. But I guess what we found at the time, and I think what's been borne out in the data since, is that I think as the issue was raised with codeine dependence, we actually saw more people heading into treatment and asking for help then, as we did sort of after the product became unavailable. But I guess, the story in Victoria is, I think that in Australia, I think it was originally sort of proposed for rescheduling in 2015. The decision was made in 2016. It wasn't implemented until the start of 2018. So it was a very long lead time. And I think there was a lot of work, and really important work, that was done over that lead time to let people know about the change, to let people know what treatment options were available. Some of those products actually became out of stock, and so there was already kind of a dwindling supply as we got towards that rescheduling. And I think the fact that it was gradual and there was time to prepare and that there was an investment. I think there was $1 million investment in educating healthcare professionals and providing information for the general public about the change. I think all of those steps in implementation probably can be attributed to the reason that we didn't actually see an overwhelming kind of problem right after the rescheduling, because there was so much preparation for it. And I was, as one of many people that was involved in many meetings, kind of trying to look at how we might raise awareness and make sure that if people were likely to experience problems, that they were able to access help beforehand. And some of the research that we've done afterwards has suggested that we didn't see big effects in substitution in terms of prescribing. We did actually see, possibly some benefits for people, and also pharmacists have reported that, that they've actually felt like there's been some benefits from the change. But I think it all comes down to that preparation and that lead up. We did know that there were, quite a large number of people that had reported in things like our national household surveys that they were using codeine non-medically and that they would find it very difficult to stop. So the fact that that we didn't see those problems, I think, suggests that something along the way was able to provide some kind of strategies for people. But I do think in the absence of that preparation, that you might see a different outcome.
Agreed. And I think the concern was that maybe, and as I say, I don't live in New Zealand, I don't know, but maybe New Zealand hadn't given the lead up time like we did in Australia. And I think you're right. I think that made a significant difference.
Yeah.
That's all the questions we have, Suzanne. So thank you very much for your presentation. I wish you every success with the tool. I'm hoping it's going to be used widely and be useful for client care. And definitely appreciate your time in sharing the development and the effect of it with us today. So thank you very much, Suzanne.
Yeah, no problems at all. And I hope it's useful to somebody in the audience. And I'm very open to people following up with me if they do have further questions that I wasn't able to kind of really speak to in terms of the presentation.